abdominal pain you're going to deal with in the emergency department. You're going to see a lot of it. Start out, of course, which puts them at risk for what? A, probably immunocompromised. B,
stomach ulcers.
so yeah, stomach ulcers. But what's the biggest thing? You get upper GI bleeds that relate to varices. Probably got portal hypertension because his liver's so scarred in because he's been drinking for years. That and just the fact that he's been vomiting blood and he says handfuls and handfuls. I don't necessarily believe that, but the guy's not taking care of himself. Those are all red flags. So getting into this lecture. So approach to abdominal pain. So important you recognize this. Again, you're only going to diagnose what's on your differential unless the CT scan comes back and says here's specifically diverticulitis or whatever. Again, reference material. It's about 8 to 9 pages. Now just keep in mind, everybody, you get to phase 2, you do, all your syllabus is going to be related to titinality, but by that time you'll probably be switched over to PAEA. But if you want to access titinality, you can get on Stimson Library, Horrible, UNMC Library. There's a walkthrough on the phase 2 page. Tell you exactly all the hyperlinks to click through that so you can get access to this. I don't expect anybody to be using any money to buy books. You should have them all electronically, unless you're weird like me. You got to have the paper in your hand. This is how I am. Come on. Okay, here's your objectives. Here's your objectives. Just going to get into a little bit of pathophysiology to bring you guys back up. Not that you guys aren't smart. Folks aren't smart. I'm just saying it's been a while since AMP quite done a lot of that stuff. Kind of bring that in to get a little bit of better understanding of that. And then we're going to kind of meld this idea of we're looking at symptomatology as well as location. It becomes important with the abdomen. It becomes important with the abdomen. We need to understand the pathophysiology. And then especially how we attack this in the emergency department. So here's your bottom line up front here. So most abdominal pain is going to be benign, but some of it can be deadly. So your job is to determine the morbidity, aka the suffering with that. And be aware that there can also be extra abdominal etiologies. These can be above and below the abdomen, where intra-abdominal is in between. So we're going to use all different types of modalities here. We're going to use our knowledge base, our gestalt, physical exam, point of care ultrasound, which you will get an introduction in your block 5, and then we have what's called formal ultrasound, where you have somebody who's trained usually for at least a year as an ultrasound tech. So using labs, CT, CT angiography. So we want to make sure that we're finding our high-risk groups, patients that are requiring admission and/or surgery. So want to eliminate useless workups when we can, based on our patient population and presentation. So we need to be methodical about this. So when we're dealing with abdominal pain, make a decision, do we want to do labs or not? Do we want to get imaging or not? Medications or not? IV fluids or not? So making sure you're getting that safety net in place. Act quickly, getting your history of present illness, physical exam, ultimately improving these patients' conditions. So what types of things do you think you can do to help your patient urgently as you're working them up? I encourage you to do this. You want to make your patient comfortable while you're trying to figure out what's going on with them. So are they dehydrated, they're tachycardic, they need IV fluids? If they are feeling nauseous, definitely giving antiemetics. It's a lot easier to give that up front, or an emesis bag versus having to clean that up. So pain medications, maybe once that IV fluids start, unless they were pulled from a warmer, maybe they need a blanket. So just give an idea of those. So goal is to figure out what's going on with your patient as quickly as possible, be successful, be efficient in the emergency department. You start out initially, you're probably going to see like one patient an hour. So you need to be able to get faster than that, quicker than that, more efficient than that. So why is it so important? This is the #1 chief complaint in the emergency department. And obviously it's going to be influenced by patients' demographics. So keep in mind, male, female, childbearing age, not. What is their past medical history? Have they had surgeries? So a lot of times if they've had a surgery, probably don't need to have that same type of surgery, but we're making sure that we're trying to figure that out. So acute abdominal pain is defined as sudden onset of pain with or without nausea, vomiting over hours or a few days. So very important that we get a history, physical exam, labs. So usually going to require some sort of imaging in the emergency department. It's very rare that I will order labs on somebody and not get some type of imaging. What I want you to do with that though, I don't want you to take everything and put all your eggs in the basket of labs. What I'm saying is when I walk out of that room based on my physical exam, that person's getting imaging. I'm not going to let the labs muddy the water. So, I'm not gonna get imaging now because they don't have a leukocytosis, don't have anything? No, based on my physical exam, if they're in enough pain, I have enough findings in my physical exam, I'm pulling the trigger on some type of imaging. Not gonna let the labs muddy that water. Please don't do that in phase 2. Make your decision right off the bat. So, Gestalt is important with these. How does that patient look? How's their vitals? Are they sick versus not sick, stable versus unstable? When I have PA students sort of in the emergency department, that's the first thing they walk back and tell me. They say sick or not sick, stable, unstable. If they say sick and unstable, we're not gonna sit there and have a 5-minute conversation about that patient. We're gonna go into the room and then they're gonna tell me that. We're gonna temporize whatever we need to do. So, now we get to the pathophys. By the way, everything on this lecture is not testable. All right, this is just the first lecture to bring everybody in so they have an understanding of a good framework for how we attack abdominal pain, because you have to be methodical about it, what you're gonna do. So, we'll talk about that. Here are the 3 different neuroanatomic categories. Neuroanatomic categories. It's important to understand this pathophysiology because it helps you understand the disease processes and how they present. So, the 3 anatomical neurogroups: visceral, parietal, and referred pain. So, right here, visceral. So, obstruction, ischemia, or inflammation are going to be the cause of that. Visceral is brought on by those 3 major processes: obstruction, ischemia, and inflammation. So, there's this stretching of unmyelinated fibers in the walls and capsules of organs. So, these are typically hollow organs. So, they have a lumen. So, usually described not great, so crampy, dull, vague, or achy. So can come and go or can be constant. So this is usually localized at the approximate level of the spinal cord, which makes it poorly described, And we take this next step forward. We can even go back to embryologic origin. So this is due to afferent nerves that take the signals to the brain, following the sensory cortex at the level of the spinal cord. So this is where they enter, determined by the embryologic origin. So think of coronal cysts if you're sitting at the foot of somebody's bed, and you have the foregut there, which is going to be more epigastric pain, the midgut more periumbilical, and the hindgut is going to be more suprapubic area with how those can present. Again, not testable. Then we have our visceral pain. So visceral pain, I want you to think about this is more appendicitis. So intraperitoneal organs, they're innervated bilaterally. So that means that regardless of whether that's on the right side or the left side, it's going to be viewed as the center initially. Used as a center. Right there, T10 is going to be visceral at about the appendix right there. It's going to be a T10. So an obstruction, distension occurs there. Pain is felt midline, and then we'll move to the right lower quadrant. If you talk to people, most people, anybody here had an appendicitis, you don't have to raise your hand, but a lot of people will describe that I get periumbilical pain, and then over days, it slowly moves down to the right lower quadrant where the actual appendicitis is occurring. So, just give you an idea of that. Versus your parietal pain, so that is when it's pushed up against the peritoneum. That's why it transitions from that visceral pain to that right lower quadrant pain, because now it's getting inflamed and that is touching on the peritoneum, that outer wall. So specifically going to be described as a dermatome then, once we're getting that significant inflammation. We're going to describe that. So that peritoneum, the serous membrane lining of the abdominal cavity, once that gets irritated, then we're going to be able to localize. The patient can localize their pain a lot better. You'll also be able to localize it a lot better when you palpate on the abdomen. Please make sure you're bending their knees. It's a lot more comfortable. As that process evolves, switches over to more of a paired heel pain, causing sharp localized pain, and then we get worried about when we start developing something called a peritonitis. That is pretty significant inflammation, probably underlying infection that's occurring there. So these patients are going to remain immobile, whereas you think more of a kidney stone, they're going to be writhing around back and forth. These people want to remain completely still, so appendicitis, please still. Then we get into referred pain. So distant from the diseased organ, this is where we start having pain that can radiate down to the testicle. Again, relates to developmental embryology again. But your examples there, your ureters, your testes once were along the same innervations. So we're going to have that radiating pain that's going to radiate potentially down to the testicle. So what other types of things can you think of? We're talking about testicular pain. So we can have kidney stones that can radiate all the way down the ureters. So what other types of things we think about that? Testicle pain. Torsion, epididymitis, hernias, based on whether they're either incarcerated or they're strangulated. So usually perceived on the same side, so it's going to be ipsilateral, not contralateral. So felt in the midline only if that process is actually in the midline, actually is in the midline. So getting onto clinical risks. So we need to make sure we're paying attention. Is our patient critically ill? So big picture. So I told you guys you have your HPI patient, your history of present illness. You've got plenty of time to discuss what's going on with that patient versus the patient that you need to be getting after, your ABC patient. That's airway, breathing, circulation. Sick or not sick, stable versus not stable. If they're critically ill, you should be simultaneously resuscitating them as you're getting what type of information you can get. So critically ill, what do we look at that? We're going to look at vitals, vital signs. Are they febrile? Are they tachycardic? Are they tachypneic? Are they hypovolemic? Do they have any altered mental status? Are they in severe pain where they're writhing around, they're screaming? And then active hemorrhage. Very difficult when we're talking about bleeding inside of the abdomen. Very difficult to assess. We're going to rely a lot on vitals. These are other risk factors. So did they recently have surgery? Are they a trauma patient? Are they pregnant? Diabetes, AFib? And then we can mix it all up and we can have difficult getting an assessment on these patients because they have some underlying medical problem, whether that's cognitive impairment. So maybe this patient doesn't have the ability to talk, or we deal with our patients that are transplant patients. We get very concerned about those because they're usually immunosuppressed to help out with that transplant. So again, start working in a clinical environment. I need you to think of worst case scenario. Worst case scenario. We're not surgeons, so we're not going to be doing the surgeries in the emergency department, but our focus is to get our ABCs, get that patient straight so that we can get them up to the OR in good enough condition to get surgery done. So primary assessments. So again, remember the battlefield, we usually move that to HABCs, but ABC is very simple to go in and check. I want to check patients. If their airway's intact, I simply walk up and ask them their name. If they can respond to their name, their airway's intact. Hey, breathing, throw a stethoscope on there, make sure they're bilateral and labored, and then go ahead and feel those pulses, all four extremities, and we move on as quickly as possible. So, patient could appear sick, critically ill because they're unstable and sick, but we need to be concerned about certain age groups. So, I'll show you in the next slide here, but age groups, we need to be worried about the severity of the pain, if we have abnormal vitals, severe dehydration. Keep in mind that visceral involvement, visceral types of pain can result in pallor, diaphoresis, sweating, vomiting. So address these categories in the next slide. Right here, extreme ages. So that's old people and young people, very concerning. So I want you to pay attention in the future when I'm giving you demographics on specific disease processes, what patients are going to present that type of way. So it can occur in any age group. But I'm going to tell you appendicitis is more of a pediatric type of thing. We'll get into that in the next one. So severe pain, are we worried about maybe this is not just an abdominal type of thing, we're about aortic dissection, AAAs, ectopic pregnancies. So abnormal vital signs, are we also dealing with the sepsis picture, hemorrhage picture? Is that sepsis because they ruptured from an appendicitis? Keep in mind these things can run together. Dehydration, we've talked about DKA, and then its friend hyperosmolar hypoglycemic syndrome, and then your visceral involvement as well. Just keep in mind you can also get some swelling in the liver from congestive heart failure that can appear almost as an ascites type of picture. So, keep in mind you're going to have somebody that's 70 years old that's very healthy. You can have a 40-year-old that has all different types of comorbidities, and that can escalate the situation very quickly. So be aware, pain does not equal how severe the illness is. Sometimes you can have somebody that's not in that significant amount of pain, they can have something very significant going on. You should be able to see a kidney stone from across the room. Anybody's had kidney stones. I've talked to a lady that's had several kids. She said kidney stones worse than pregnancy. I haven't had either, so I don't have any worse in the game. I don't have any worse in the game. So just keep in mind that maybe when they come in, you think somebody that lives at 180 systolic blood pressure, and they come in and they're at 110, you think, oh, 110, that's good, that's healthy. Not if they're normally at 180. Just keep that in mind. I go back and check vital signs. So just be worried about those masking, especially in the elderly and the immunocompromised. They can tank pretty fast. Plus, a lot of elderly people don't necessarily want to come into the emergency department, so they might not be so honest with you. So medications can also mask these as well. So if they're on hypertensive medications, may not show up as obvious. So shock can develop pretty quickly with this. So systolic blood pressure doesn't drop until we've lost about 30 to 40% of blood loss. That's not good. That's a lot of bleeding that can occur. That's almost 50%. So tachycardia is very helpful, but just keep in mind if it's absent, it doesn't exclude a blood pressure. So we can get these orthostatic vitals, and what's positive for orthostatics? Usually a drop in systolic by 20, or 10 diastolic, or an increase in 30 after standing, increase in 30 beats per minute. So, critically ill, so just keep in mind tachypnea can be cardiopulmonary, but it can also exhibit from a metabolic acidosis, anxiety, pain. So when we see tachypnea, I think of two different things right after that. So obviously DKA with too small breathing, and one type of overdose. Anybody have an idea of overdose that's going to cause a metabolic acidosis? Probably number one. There's several different, but number one, aspirin. Aspirin. You'd be thinking tachypnea, think aspirin. Think aspirin. So, and we don't put a lot of credence on somebody's temperature, but just be aware, because maybe they took some medication, they come in, and now they're not febrile. Maybe they took some Tylenol just a few minutes before. So just be careful with that. So expect you to be here in phase 2. In knee deep in it, obviously you're the one right there. When somebody comes in with EMS, you should be in the room right away getting reports. They're only going to stay long enough to get a report, and then they're getting out of there. So they're going to jump back in their rig and get back out and pick some more people up. So just be aware, you need to be right there to be assessing your patients. So when we do that, we've talked about this critically ill abdominal patient. So we want to make sure, because sometimes this can mimic in older people, especially with epigastric pain. So getting them on a cardiac monitor, oxygen. So 2 large bore IV access. So I thought it was very interesting, that video, that guy's dehydrated and tried to give him fluids and everything. Anybody see what size gauge catheter they were putting in him? It's pink. It's a 20. Come on, guys. Big sauce. So large bore, when we say large bore, at least an 18, if not a 14. So isotonic fluid, yeah, most of these people are going to go with LR, because we're about normal saline causing potential metabolic acidosis. Most emergency departments nowadays are going LR. So, and if need be, because the patient doesn't look good, let's get that crash cart and airway cart to the bedside. Every ED has those. People come on shift in the morning, they're supposed to inventory those, make sure that everything's good to go, so we roll it in the room, ready to rock and roll. So technically doesn't break down exactly how all these labs work, because you're not going to order an electrolyte panel, okay? But you're going to order a basic metabolic panel, and you wanna roll everything up and get it all, you need to add a calcium and mag to that. So BUN, creatinine, that'll come out in that B and P. CBC with diff will cover you for your CBC platelets. Coag panel to cover your clotting studies. Type and screen, if you're thinking about giving blood, if you want to give blood, we need to go to a type and cross. Type and cross. That patient comes in, they're hypotense, and they've been bleeding. Let's go ahead and get that type and cross. And then potentially, if they get a little bit older, some other things to think about. Epigastric pain, I'm probably gonna throw a troponin in there. And if I'm worried about sepsis, or they've been drinking a lot, I'm gonna order a lactate, and then potentially epigastric pain as well. What do we order to rule out a pancreatitis? Lipase. No more amylase, lipase. Amylase is old school, you get scuffed up. So, again, there's your type and screen, breaks down exactly what blood type that they need. A type and cross is gonna make sure that they can take that actual blood, and that they're not gonna have a transfusion reaction. Okay? Nothing makes the situation worse than you're giving somebody blood and they're having a transfusion reaction because they need the blood, and now you have to stop it. So, high likelihood. If I'm on the fence, just order the type and cross. Most places are pretty good with that. Well, other types of things we can do. So focus. We're not going to get big into doing a bunch of things with the abdomen. We're probably going to teach you guys EFAST. Not probably. We are. DVT, ocular. Give you some soft tissue stuff that you can do, and maybe some vascular access. We used to teach things like this before. So that picture to your left is going to be a AAA scan. So a AAA scan, so you're going to scan all the way down the aorta, looking for anything that's above 5. That's bad. 6 is not good. That might rupture, but those are very difficult, and not a whole bunch of utility in a patient population under the age of 50. Okay, that's more an old person's disease. And then right there to the right is going to be just some examples of EFAS photos. I need to get you guys too fired up on that. It's better once you've done a couple of these. But EFAS gives some idea. So if there's any free fluid in the abdomen, we don't call it blood, we just call it free fluid. And then we need to see if there's a pneumothorax or any evidence of cardiac tamponade. So, okay, and then we need to look at these past medical histories. We need to look at any recent abdominal surgeries. And yes, people are poor historians. You have any abdominal surgeries? Nope. And then I think, like, what's that scar from? Oh, I had my appendix out. All right. So please expose somebody's abdomen. Make sure. We talk about pregnancy and menstrual history. Any pregnant patient, we're going to get our, they talk to you, Florida Power and Light is how I remember that. My acronym, full term, preterm, abortions, living children, Florida Power and Light. So make sure you get all that stuff. If you have a pregnant patient, you don't give them that information. OBGYN is going to tell you to call them back when you have all that stuff. So again, medications, allergies, recent trauma. I want to give them any medications they might be allergic to, and then just get an idea if they have similar pain, similar episodes in the past. Okay, review previous medical records. Hopefully that patient, if they're incapacitated, they're altered anyway, hopefully they brought somebody with them that can explain all that stuff. But then we want to get into all their social history. So alcohol use being a big one with that, because that just puts them at huge risk for them having portal hypertension and some underlying esophageal varices, which puts them at a huge risk for upper GI bleeds. We'll do a whole lecture on that. So social history, I break that down into nicotine. So technology is still old school and breaks it down to tobacco. Occupation for different types of toxic exposures and the living circumstances can come into play with whether or not you want to discharge or admit them. Alrighty, so immune dysfunction, want to make sure. So what's a big one if worried about immune dysfunction? Hopefully you get this when you say past surgical history. People that don't have spleens, be very worried about being immunocompromised. So just give you an idea of that. So opportunistic infections, especially with our HIV population, not likely going to see a lot of that in the military, but I trained in downtown Seattle at Harborview, and I'd say probably every 10th patient had HIV. So Made things for very interesting, a lot of opportunistic infections. That's not just bacterial, that's viral, that's parasitic, that's fungal. All 4 flavors of those. All 4 flavors of those. So you get your ABCs done if you had to resuscitate that patient. Now you can kind of got them looking a little bit better. They're PO tolerant, they're getting IV fluids, they're looking, I thought you can start spending more time on your focus, history, present illness, and your physical exam. So again, your OPP, QRS, So, and then they throw in another T. Here's what technology's been out of this, and what are they taking for pain? Want an idea of that? What are they taking for pain? So gaining the patient's trust, very important as far as getting their rapport, maintaining their modesty as well. So exposing one part at a time. These aren't necessarily something you need to get trauma naked. That is a thing. It's more of a downrange thing or a trauma thing. Usually not regular to do that, but when expose those parts sequentially, also making sure they're paying attention to the patient. What's the color of the skin? Touching their skin, the temperature of it. Calor, if it feels hot to the touch, we need to be concerned there's an infection. Skin trigger, we need to know how to do that. It's gonna pinch the skin, okay, give us an idea of if they're dehydrated or not. Just another way besides looking at vitals, perfusion status, and then targeted heart and lung examination because we don't wanna miss those types of things as well. That could be a referred pain. Always inspect this. Inspect the abdomen, looking for ascites, ileus, obstruction, volvulus. So looking for masses, looking for any surgical scars. I had a resident of mine that didn't bother to expose the abdomen and completely missed an incarcerated umbilical hernia on a kiddo. And the attending was not very happy, and I gave an answer to that. But you can identify those surgical scars. So why do we want to identify surgical scars? Aside from just checking, are they clear on their past surgical history?
Adhesions?
What does abdominal surgery put people at risk for?
Adhesions?
Adhesions. And adhesions roll into small bowel obstructions. So multiple instrumentation inside the abdomen, higher risk for that. So surgical scars right there. Ecchymosis, just to see is there any type of trauma, is there any type of bleeding diathesis, which would be indicative of potentially some type of liver issue, as well as your stigmatic liver disease, so all that stuff. So you have blood vessels coming up to the surface, pulmonary erythema, caput medusa. I've never actually seen that, but it looks pretty interesting. So bowel sounds, very important to take a listen to that. It's the other thing when I'm going to auscultate the abdomen, I said the patient was super apprehensive, and every time I went to palpate their abdomen, they like freak out at me and scream.
Murphy's
I can't tell you the number of people that I go and I do the same thing with my stethoscope and apply just a little bit of pressure, and I'm completely fine with that. I'm like, I'm doing the same thing that I was just doing with my hand. So that's called what else signs, and you take that for your, don't start screaming at people and kick them out of the ER, but just be aware of that. So decreased bowel sounds. Give us an idea there's an ileus. It thinks we're not getting that normal peristalsis of the abdomen. Mesenteric infarction. So typically a person that has atrial fibrillation. So narcotic use, peritonitis. So working hyperactive. So high pitched tinkling, usually small bowel obstruction. But please auscultate the abdomen. Very non-specific, but you want to check that. Yes, we do say liver size can be estimated. I still don't put a lot of utility in it. I'm so glad you guys do it for the whole man. But yeah, I think I've done it since phase 1. So, but we do want to make sure that we percuss. So make sure there's no distension. We can check the fluid wave. And then again, if we have Tiffany, we should have some hyperactive bowel sounds with that, giving us an idea of dilated loops of bowel, says small bowel obstruction of ileus all day long. So, again, make sure we palpate that. So I look for voluntary guarding, which means that they are doing that on purpose if they think they're going to feel some pain. It's going to be a lot different than what we're actually worried about with actual guarding, but voluntary guarding. Want to make sure that we can distract the patient. Again, palpating with the stethoscope is another way to do that. Again, rigidity, much more concerning. That is not voluntary. That means we probably have some peritonitis going on. So that is reflex, involuntary, max tenderness when we palpate on that. So rigidity plus referred tenderness Pain and coughing is usually enough diagnostic confirmation that we're dealing with peritonitis. We should be very concerned that it's a serious abdominal issue going on, whether that's an infection or just significant inflammation. So again, palpate that. Rebound tenderness has been shown to not be super great. So look at that. A third of people with no rebound tenderness still have an appendicitis. Still have an appendicitis going on. So false positive with that. If it's anything below the umbilicus, any pain below the umbilicus, okay, the belly button, that's going to warrant you doing genital exam, male or female. So a woman comes in, she's getting a pelvic. She's going to get a pelvic exam. Gentleman comes in, you absolutely have to do an exam to make sure you check in the groin, testicles, everything to make sure it's not something that you missed. Seen it missed quite a bit. The only time if they've had a complete hysterectomy. A complete hysterectomy, that's ovaries and uterus. Ovaries and uterus. So if they still have ovaries, there's still potential for ovarian pathology, whether that's tubal ovarian abscess, potential even still for ectopic pregnancy if they underwent in vitro. So peritoneal signs, want to make sure we're checking that. Very concerning. Cervical motion tenderness is indicative of what? It's pelvic inflammatory disease until proven otherwise. Pelvic inflammatory disease, which is why we do checks on all those, and you're going to do it bimanual. Get a chance to do that at RTA. Bimanual, making sure that you're checking the fallopian tubes. So the last ectopic that I caught at BAMC, I did my bimanual, and the lady had right-sided tenderness, the fallopian tubes, ovarian tenderness. Sure enough, right-sided ectopic pregnancy. Sure enough, so. Again, making sure that we check males, hernia, testicular, prostate exams are all indicated. Get an idea for lower abdominal pain. Any abdominal pain below the umbilicus, you need to be checking this. So, palpating, consider rectal exam. DREs are very important, yeah. Stool WIACs are kind of gone out of favor a little bit, but you want to get an idea to see, hey, do we see any gross blood down there? And then, is this rectal bleeding or is this lower GI bleeding? Because the number one cause of rectal bleeding is what? Hemorrhoids. Number one cause of lower GI bleed, diverticulitis. Okay, two different worlds. I want to make sure we check that. Do we see any fistulas? Do we see any hernia or any hemorrhoids, anything like that? And then I also want to get an idea and just I want to quantify the amount of rectal bleeding that I'm seeing. Quantifying that. So we talked a lot about pathophysiology and how that relates to where the pain or how the pain presents and whether it's sudden, does it come on slowly, does it migrate, things like that. I want to have an idea of that stuff. But I also need you to understand that there's location. So we meld these two with our presenting symptomatology with how does that pain and where is it up. And now I'm going to focus a little bit more on coming up with your differentials. So conceptual framework for understanding this chart is locating it by quadrant. And then also at the top there just kind of says diffuse pain. It doesn't really help us out a whole bunch. It really help us out a whole bunch. But we also want to focus on extra-abdominal versus intra-abdominal. So we can tear a rectus muscle, testicular torsion. Maybe they have a herpes zoster flare-up that's on the abdomen. Now how do we know that's herpes zoster? Is it going to cross the midline? Nope. Going to scan that dermatome. So DK, sickle cell disease, is this an MI that's presenting as an epigastric pain, pneumonia? They get bit by a black widow on the stomach, I don't know, or anywhere else, and now they're having pretty significant abdominal pain versus all the other stuff that we will get into. Then you have your non-specific stuff, gastroenteritis, gastritis, enteritis, colitis, polycystic ovary syndrome. So, location of the pain, the symptoms, patient's gender and age are all going to help you get with your differential. Now, it doesn't mean you take something completely off the differential, but you should have them kind of rank ordered based on, I think it's probably one of these top three, but it could be some of these others. So, conceptually utilize the patient's demographics. So, I'll tell you why. Elderly people are more likely to have biliary disease, diverticulitis, or obstructions. young people have appendicitis. So right off the bat, you should be able to look at that. Younger people, younger women of childbearing age, more likely to have PID and ectopic pregnancies. So have those types of things. Your patient comes in and be like, okay, this is probably going to be higher on my differential. Not saying to take stuff off completely, but just kind of rank order those. Now, so we got our ABCs, we got our history, present illness, physical exams complete. So no intervention has been required yet by the patient. Now it's time to address your patient's symptoms and treatments. So, and again, at this point, you should have already done your primary survey. So this is where we're going to reach for IV fluids, potentially antipyretics. This is where I look at vitals, and I should be doing something in the emergency department if I find an abnormal vital. Everybody gets fired up about like an O2 of 92. I don't get excited about hypoxia until they're below 90. Okay? Most people rock around at 92, but they're going to be just fine. So, and then potentially do our reach for narcotics. So, back in the day, they used to say, don't give your patient narcotics. You have to wait for the surgeon to come down because you're going to mask the pain that the patient's going on. We don't do that anymore. Do not withhold pain medication because it's going to obscure a physical exam. Never withhold any pain medication unless it's going to harm your patients. Now, that being said, let's talk a little bit about medications. Which do you want to be careful of? Which medications, especially narcotics, do we want to be careful of? I'll tell you, it's pretty only one out there that I want to be real careful of.
Morphine?
And that's morphine. Okay? If that patient is hypotense, if you want to run a code, have fun. Don't do that. But you got to be real careful with morphine. If that systolic blood pressure is not at least 100, you need to find different medication. Okay? Why? It's morphine, causes histamine response, blows the blood vessels wide open. If you want to put somebody into a shock and give them morphine, especially if they're narcotic naive. No, stay away from that. So there's other medications. You can do small doses of fentanyl. Dilaudid is a great one. So a milligram of Dilaudid in your patients that are a little bit hypotense because you still want to take care of. Just be careful with morphine. I've seen people get in trouble with that. Last thing you want to do is give somebody morphine and then have to turn around and give them Narcan. It's like you just wasted 2 medications. So antiemetics prior to narcotic medication. I always do this because I'm not sure how that person's going to handle their narcotics. So worried about a GI bleed, we need to be considering an NG tube, or if they have an obstruction. So, and then what tubes do I need to place? Other ones to consider, urinary catheter. Why? That can be diagnostic and therapeutic. It's going to be therapeutic because they were retaining urine. Diagnostic because you're going to figure out is there an underlying infection going on there. And then we get our laboratory testing. So does not take the place of that. Fortunately, with a lot of these folks, if they come in for abdominal pain, somebody triaged them out in the waiting room, they've ordered all the abdominal labs. Ideally, by the time that person gets back to the room, you walk in, you have all their labs, you're doing the physical exam, and now you're just figuring out which imaging you want to order. So be aware of the limitation of these studies. Has that CBC, is it too early that the anemia hasn't shown up or the leukocytosis hasn't showed up? And then we talk about BUNs and creatinines. If BUNs elevate, then we're worried about potentially there's a GI bleed because the BUN elevates because of the breakdown of blood in the GI tract. So every female patient that comes in to ED pretty much gets an HCG, childbearing age, but sometimes they're not sure, they're premenopausal, this type of thing. Yeah, I have had to tell a 58-year-old lady that she was pregnant. So don't throw it out there. Rather to have it and go off the lab than mess it up. So older patients, diabetics, they're going to get an EKG, especially when they're saying, I might have gastric pain. Last thing you want to do is be working somebody up for abdominal pain, and that EKG would have shown you ST elevation. Again, not everybody requires imaging. I'd say that most people from the emergency department maybe are a little bit more cavalier, and we do order imaging. And sometimes the surgery department, you get a right upper quadrant ultrasound, it says cholecystitis, and they're like, cool, yeah, I want the CT still. They want to see everything that's going on there, even though that should be enough. But that's why I talk to the surgical consultation. If it's earlier and it's like 5 o'clock and I know they're gonna take off and head home for the night, there's potential that I'll call them and say, I'm pretty sure I got appendicitis down here. I'll give you a call back when we got the imaging. So, should give them a heads up. So, here's all your labs, just reasons why. I would look this chart over. I've not spent a lot of time on this. Again, all your patients are going to get pretty much a CBC. Now you can get a CMP, or you can get a BMP with LFTs. That's what a CMP is. But if you get LFTs, you're going to get bilirubin with that. So lipase, UA, and pregnancy tests. If they're dehydrated, I might just go ahead and get the blood tests rather than waiting for the urine, because the urine may take a while. If they're older, definitely get coax on the elderly. Lactate concerning for sepsis or ischemia. Troponin for any type of epigastric pain. You do not want to miss that. They could be having an acute coronary syndrome. Just some other tidbits here. So, we already said that a third won't have rebound tenderness. Well, look at this. Only about 65% had a white blood cell count over 12 for appendicitis. Just be aware of these limitations. If we need to, we can get serial labs, we can do serial exams. If you don't feel completely comfortable, you can admit the person to this. I want you guys to do serial labs, serial exams. So, right there, acute mesenteric ischemia, and this should typically present as pain out of proportion on exam, POE. So, this is ischemia. This is an older person that probably has AFib, grows a clot in their ischemic arteries. This is bad, but only 25% of those. 1 in 4 will have elevated lactate. Lactate is an idea of ischemia, but just be aware of that. What are other reasons that can cause leukocytosis? So we can have a marginalized leukocytosis just from being stressed, from being in pain. So maybe that person's been on steroids. Maybe that patient is pregnant. So cancer and autoimmune diseases can also cause white blood cell counts to be really wonky. So, increasing lactate tells me that I probably need to get another lactate to see if it's going up or going down. I only have that snapshot of time. I need the second one to see is it going this way or this way. If it's going this way, that's not good. So, acute abdominal surgeries have come out of a lot of favor. They are very useful in trauma patients. They're useful in when I need to let the parents know that their kid is constipated, because they don't understand that. And it's simple. I mean, the kid hasn't had a bowel movement in 4 days. It's pretty obvious what it is. For whatever reason, they don't want to poop at school, not enough fiber. However, again, just not a lot of utility in this, other than maybe an upright would show you if there's any air where it's not supposed to be. So they say plain radiographs obtained, ensure the inguinal region. To identify incarcerated hernia, now you should identify that on physical exam. So you find that hernia and you can't reduce it, it's incarcerated. And that becomes a surgical emergency. But again, free air potential if we get that upright. So I don't know how they came up with this, I just thought it's interesting. So radiologic evidence of small bowel movement seen 6 to 12 hours before symptoms. Did they just randomly start x-raying people and then figure out who had small bowel obstructions? It's worthless. So if you need to, I'm just saying don't put a lot of utility in x-rays. So ultrasound CT scans, much higher sensitivities. So just remember that surgeons sometimes do prefer to see all of the abdomen. And I think we are due to take a break. Questions? That is pretty much tells you what you should only be using x-ray for. Abdominal films right there for obstruction, sigmoid volvulus, perforation. I say perforation and severe constipation. The only two things that I would even consider that for. So again, ultrasound, CTs much higher. Plain films, younger patients, classic signs and symptoms of constipation is probably number one. We got our ultrasound here. Great visualization for right upper quadrant. We're looking at the gallbladder, pancreas, and also look at kidneys, ureters. We get an idea of urinary bladder volume as well as dimensions. So So free air is very operator dependent. A lot of ultrasound is going to be very operator dependent. So you get your experience, you're going to practice on each other, you're all young, healthy folks, a lot easier. You start getting into older folks, you start getting into people that have a lot more adiposity. So again, biliary tract is going to be ultrasound, is going to be the preferred imaging modality. So acute cholecystitis, or something that's called biliary dyskinesia, which is just like a sick gallbladder. It doesn't contract and put out all the digestive juices that it's supposed to. So, and if worried about that, there's potential for scintigraphy. So again, bedside ultrasound, urinary retention, very useful. Some places do have something called a bladder scan, which they just hold that up to the bladder, they push a button and it tells you exactly how much volume's in there. You can calculate it with ultrasound as well. If you have the butterfly has AI built into it, pretty cool. Push a button and scan transverse and sagittally, and it'll give you exactly how much urine is in there. Very useful, but for the most time, we're going to be using CT scans. CT scans, useful, but just keep in mind, it can cause some delays, but increases the throughput, especially if we're adding contrast to that. There's going to be only certain times that we add contrast to that. Only times that we add the oral contrast, I should say oral contrast. You make a decision between IV contrast, not. So regular CT scan, no contrast, that's going to be for kidney stones. CT scan with IV contrast can be for everything else, and then we have to update it or upgrade it to oral. That's probably because we're dealing with a bariatric patient. So post-bariatric surgeries. Keep in mind, if patients want to know, they're getting about 10 times the dose of radiation from a CT scan as they do from a regular X-ray. Somebody wants to know, hey, how much more radiation is this? But in the emergency department, we've got to figure things out. It's worth the radiation. Worth the radiation. Now, we're very careful in this in younger patients and pregnant patients. Very careful in that. So there's going to be some shared decision making potentially with that. So you have all these different flavors. You have your non-contrast, like I said, with kidney stones. You have PO. You can also do parectal and then IV contrast. So just be aware of these are all going to be a little bit different based upon the protocol for your MTF, based on what you're looking for. If you have a question, you can always find your radiology folks and ask them, hey, here's what I'm concerned about. Which study should I go for? And they can help you out with that. Again, there's your non-contrast CT, diagnosis of the kidney, as well as your renal stones. So oral contrast, abdominal pain, been called into question over the years. So some places have decided that this is what they want to use it for. Most of the time it's going to be for an abscess, a perforation, a fistula. It's going to give you a better idea. It's going to show additional contrast that goes through the GI tract. Yes, they have to swallow that, so keep in mind if somebody has significant abdominal pain and now you're going to have them drink a whole bunch of contrast, that can become problematic, especially somebody that's nauseous or has been vomiting. We've got to get pretty heavy on our antiemetics if we're going to have them drink a bunch of contrast. And then in some cases, a rectal contrast, we're worried about a distal large bowel obstruction. So IV contrast, almost always this is going to be the right answer except for kidney stones. Shows better visualization of the bowel mucosa, the visceral organs, as well as vascular structures. Especially very important with small bowel obstructions because not only going to identify how big they are, whether small or large, but they're also going to identify transition zone, which really makes a determination if that's a surgical deal versus a not. So it can potentially be an initial test to confirm a AAA rupture or mesenteric ischemia if we've not found that, provided that your patient is stable enough to go to the CT scanner. We don't send anybody to the CT scanner that's going to pass. This is just a good chart for your future, just to give you an idea of looking at all your potential differential diagnosis, and then it includes demographics and potential symptoms. I just recommend at some point if you just want to study that so you can conceptualize it. For your visual folks, conceptualize it like what differentiates this and this. You can look at demographics. Idea, again, not testable. We're going to get into all the major important ones. But I want you to pay attention. There's certain symptomatology that helps you differentiate from one to another. So this is 20 different that should probably be on your differential. and you start rank ordering them based on symptomatology, patients, demographics, and what type of labs you're getting back. So, pretty amazing chart. The last I want you to look at this column. There's a column that has to do with imaging complications, but these also help you provide pearls to help you differentiate between different disease processes. Say antibiotics, so suspected abdominal sepsis and peritonitis. So just be aware of that. We can get abdominal infections in the GI or GU tract. But just be aware we're reaching for different antibiotics for these. And if you're on the fence about it, you talk to somebody, you're going to admit the patient because obviously they have abdominal sepsis or peritonitis. Probably going to go with a big gun, but I will talk to that service that's going to accept my patient, whether that's a surgery service or an internal medicine service, and say, hey, I think I'm going to start with this antibiotic followed by this antibiotic. Probably going to cover down and make sure you cover down your gram positive, your gram negative. What I might say on the phone, hey, are you okay with this or do you have another recommendation? Different doctors based on how they trained or providers in the hospital, they have their own protocols in their own heads. So antibiotics to make sure we're covered. So a lot of these are going to be, if they're perioperative, so they want antibiotics started right away. So, and then PID, which antibiotics for PID? You know, one of them is going to be a shot, right? Herceptin, usually 500 milligrams. They used to just do 250, now they do 500. Big dose of that. And then it used to be azithro, but most people usually throw up that gram. So now it's doxy, and then plus or minus metronidazole. Plus or minus metronidazole. Again, I'm not big on dosages, but a lot of these times with these admins we need to be worried about. Your two most common are going to be appendicitis and cholecystitis. We'll talk about those later, but those are going to require surgical consultation. And if they're a high-risk patient and it hasn't quite gone that bad, we may want to admit them because they're not PO tolerant, they're febrile, they're tachycardic for whatever reason. Have a low threshold for admitting elderly folks because they can tank fast, admitting people that are immunocompromised, people that are aphasic. So I've had a few of those where they can't talk. That makes it very difficult unless you know how to sign language. Not a lot of people out there that are good at that. And again, cognitively impaired. These are people with Down syndrome. For whatever reason, they're very difficult to communicate with what's going on and getting an idea of what their problems are. If they look bad, if you can't get their pain or their vomiting under control, you can admit them for pain control. You can admit them for not being PO tolerant. So that's provided that you tried a bunch of different pain medications and you've tried a bunch of different antiemetics. You can't just say, well, I just tried pain medication, it's not under control. They'd be like, try some more. And so probably about 3 of each and different ones and different doses before you can 100% say. And then once you've got them under control, you can click a cool button in MHS Genesis that says PO challenge. And the nurse will know, get some juice or some water and some crackers and make sure that they can handle that before you send them home. And then there's your social admits. So no reliable follow-up, lack of social support can also maybe require admission. So unclear diagnosis. So even if that CT scan's negative, there is potential to have that patient just follow back up the very next day. We do that a lot with ectopic pregnancies, possibly we know they're pregnant. The ultrasound didn't show us, the HCG's there, we'll have them follow back up usually about 48 hours. Draw another HCG, make sure it's continuing to go up, otherwise we're in threatened abortion land. But very possible you can agree, shared decision making, they have the ability, they can come back in 12 hours and we'll reassess them. So make sure that your discharge instructions address certain things. If they're having some gastritis or having some abdominal pain, heartburn, there's certain things that we want to make sure they're drinking in plenty of fluids, avoiding certain types of things, not necessarily brat diet. I tell people, if you're having bad heartburn, you probably need to stay away from red meat, probably need to stay away from citric acid, things like that nature. So medications, a lot of these people want to avoid narcotics. Why do narcotics, what do they cause? They cause constipation. That's why loperamide works. So loperamide is a narcotic without the pain control properties. So it just slows the GI tract down. We want to be really careful with these. If you're giving narcotics, please give them a stool softener as well. and making sure the family is aware of what goes on, and strong, strict return precautions as well. So worsening or new symptoms, pain, fever, uncontrollable emesis, passing out, bleeding. So special populations, so we need to make sure, yes, and if it's below the umbilicus, we need to make sure we're ruling out those gynecologic diseases. So a lot of these, we're going to get either a qual. I recommend usually getting a quantitative. Qual is yes, no, binary. Quant is going to give you a number. How pregnant is that patient? Anything above a 5 is a positive pregnancy test. But this is going to come into play when we talk a little bit more about ectopic pregnancies and what we call discriminatory zones. So I want you to pay attention to that now. So any woman that comes in, lower abdominal pain, doesn't always have to be right or left, anywhere down there. I'm concerned about ectopic pregnancy if she is of childbearing age. Do not miss those. Do not miss those, but is it gynecological or not? You want to make sure. So low BP, syncope, very concerning for ectopic pregnancy. So right lower quadrant pain, how do I work out this debacle? It's like, oh, it's right lower quadrant pain. Could it be a GI disease or could it be a gynecologic disease? Guess what? Every woman that comes out has lower abdominal pain and I palpate that, she's getting a transvaginal ultrasound, period. And then we're going to move on if that doesn't come back. I'm not going to do it the other way. I'm not going to expose them to radiation when I could have found it with ultrasound. So I just go ahead and pull the trigger on that. And that's how I solve that dilemma. Now I usually have a pretty good idea which way that's going to go, but ultrasound versus CT, as long as the patient's not pregnant, right? Then I can go to CT. If she's pregnant, then maybe she needs to be admitted for an MRI. Look at all this lower abdominal pain in a woman, with a history of a hysterectomy, without a history of a hysterectomy, always gets a pelvic, always gets a pelvic. Why? Because look at all those things I have to rule out. So, and a lot of times I'll have the ultrasound department say, well, she's not pregnant. What are you getting the transvaginal ultrasound for? Not ruling out an ectopic. Well, I'm going to look at all these other things that it could be. She could have adnexal torsion. So, PID. Ruptured ovarian cyst, tube ovarian abscess. Those are 4 other things that are higher in that chart that are asterisk. So 5 out of 8 are potential threats to life. So our elderly folks, yeah, they're going to come in. It's going to be very mild, typically vague, underreported. So unfortunately, they show up late and atypically. So be careful. If they're above 80 years old, you don't make the right diagnosis right off the bat from the ER. Mortality is going to double. That's kind of scary over the age of 80. So surgical complications more common because surgeons don't mind operating on older folks, whether they're ready to go or not. And there's just a bunch of different things that can happen with that, with pancreatitis, hernias, bowel, viscous, gangrenous gallbladder. So we don't put a lot of credence in the white blood cell count in the older folks. It takes a while for that to elevate. Cholecystitis, #1 surgical entity in the elderly patients. Everybody thinks that they hear that, what is it, female, fertile, fat, flatulence? No. So right here, it is an older person's disease. So just be aware about viral gastritis is very uncommon, but we do see diarrhea with a mesenteric ischemia. Again, these people present very atypically. So any abdominal pain, very important. I'm going to have very liberal, low threshold to give them full court press. Order all the labs, including a troponin, including a lactate, definitely a lipase, and getting all those labs, and they're definitely going to get some imaging for their older. So just be aware of that. Low threshold to get them admitted for observation or serial exams and serial labs, and maybe even some serial imaging. It can just go badly. Okay, we have our bariatric surgery patients. Some places you'll see a little bit more of these. Some of the bigger MTFs. I think Eisenhower shut down, but that used to be a huge bariatric center. So low threshold on these people. A, you're going to work them up like a champ, and then B, you need to be getting the PO contrast, and you need to be talking to a bariatric surgeon to make sure. So they also are going to have a lot of malabsorption type of issues because they've had parts of their GI tract removed. But just be aware of what's really concerning: obstruction and erosion with a gastric band surgery. So, and then expect these people to have lots of issues with diarrhea due to that malabsorption. So that causes protein depletion and vitamin deficiencies and make it a little bit more complicated in treating these patients. So bowel obstructions caused by hernias. So if that, where that reanastomose, that GI tract can cause stenosis there, it can cause obstructions, adhesions. So Roux-en-Y bypass, very concerning that anytime they come with abdominal pain, it is a surgical emergency. Most commonly at the GJ anastomosis is where they can have leaks that occur, so that's why they have to get that PO contrast to really look at that. And that makes it really difficult because they're already having abdominal pain, they're already nauseous, vomiting, antiemetics, and now you're having them drink a bunch of contrast is not the funnest patient to be taken care of at all. So, leaks, if we have a leak there, we have an idea that it's potentially, we have that GI tract and all its contents being placed where it's not supposed to, giving us ideas of sepsis, so tachycardia, fever, abdominal pain. So a CT scan can show that there's extravasation of that oral contrast material. That means we have a leak where really concerning that they have to go back to the OR. So hopefully that bariatric surgeon is in the hospital that particular day because they need to go to the OR and get that taken care of. So extremely high mortality if they do not fix that leak. And then this is typical. This is why they have most people say you have to go to the bathroom if you're same-day surgery, to get an appendicitis, to get a cholecystitis. When they get in there and they manipulate inside the gut, instrumentate inside the gut, then that surgical manipulation is going to decrease the normal peristalsis of the abdomen. So it's very common for these people to have post-op ileus, so adynamic, meaning it's not moving along. So that can result in nausea, vomiting, distension, cramps, obstipation. So a lot of times they will just do a quick radiograph, typically from the PACU, so that's after the surgery. And then, but just be careful, that can be mimic a small bowel obstruction versus an adynamic ileus. Adynamic ileus can be difficult to differentiate. So very careful with that. If they hit that point, they're probably going to need a CT scan to rule out that small bowel obstruction. So obstruction of that can be very different. So if it's more proximal, we're going to have an early emesis and less distension, where if it's more distal, it's going to be a later emesis with more significant distension. So this is pretty nasty, but sometimes they can have bilious or feculent emesis. It's pretty nasty. But again, high-pitched bowel sounds. Plain radiograph is going to show the air fluid levels and a little bit of air distal to that obstruction. Abdominal CT scan, very important. If we did see small bowel obstruction or concerns, we get that. We need to see transition points, presence of any complications. That will determine whether or not they need to be surgically intervened with, or if they can just bring them in, put in a NG tube, and kind of let it ride. Just be aware, again, it's those adhesions, multiple instrumentations that cause that. And then urinary retention, there's potential. That's why we can do that bedside bladder ultrasound to see if they're retaining urine. We want them to be able to urinate afterwards. Sometimes it means going home. If we need to diagnostic and therapeutic, we can put a urinary catheter in there to get that fixed. All right, questions. No check on learning because there's no questions going to be asked in this.
Another morning to see.
Something just to get cut out.
Your own
So,
personal
reservoir
ball.
for good bacteria, where the book answer is, and then it assists with the maturation of B cells and IgA antibodies. And then the other interesting fun fact, maybe this will help you out in trivia one day, I don't know. Reconstructive surgery of the bladder, we use it to recreate a sphincter muscle in people that need one. Other than that, it's pretty useless. So, all right. This is 10 chapters, about 4 pages if you wanted to look up all this in Titnali. Only 35 slides, and we'll just finish up with this today. Here's your objectives. We're going to talk a little bit about pathophys. We'll do a check on learning, of course. But And then of course, talk to you about how we handle this in the emergency department. See, I saw a lot more of these working in pediatric emergency medicine than adults. A little bit outdated, but I want you to pay attention to. So a lot of appendectomies, and this is typically done laparoscopically now. They used to do it open, the right lower quadrant, so laparoscopically, usually in and out in a day. Actually had it working with a doctor, he actually let me do one start to finish. So pretty neat little deal. They have this cool little device that you just put around the appendix, and you like pull a trigger, it like zips it up and cuts it, and you put it in the bag and pull it out. Pretty crazy. Anyway, so 250 to 300,000. Pay attention to this. So more common in females. So like a little bit over a 1 in 10 with males. Women more than 1 in 4. So just get an idea of that. More common in women. Well, that makes things a little bit interesting because if they're childbearing age and right lower quadrant pain is like, oh, is this an ectopic tubo-ovarian abscess? Is it more of an ovarian pathology or is this an appendicitis? And then you also got to think, well, women get pregnant, so having appendicitis and being pregnant would be a little bit concerning. So, but look at that, most common ages, 10 to 19. These are going to be important things. So if I'm going to ask you about appendicitis, I'm probably going to have a patient fit closer to that demographic rather than having you guys thinking that you're searching for zebras. So look at that, most frequent cause of atraumatic abdominal pain greater than 1 year old. So greater than 1 year old, most common cause. So, and most common non-obstetrical surgical emergency in pregnancy. So, atraumatic abdominal pain acute without having an appendectomy previous, we need to be very concerned. Putting appendicitis probably at the top differential there. Now, a couple different ways that we look for these. So, again, this is appendicitis caused by luminal obstruction. So, of the vermifluor appendix, typically a fecalith. Fecalith. That's a poop rock. Okay, fecalith. Less causes, less common causes, so it can be caused by overgrowth of lymphatic tissue. Gallstones, believe it or not, can make it all the way down the biliary tract and end up in the right lower quadrant. Believe it or not. So, for all the way from the common bile duct, the intestines. Other weird ones could be tumors or parasites. So essentially you get this stasis from the obstruction. Stasis in the body is never good. It allows the opportunity for pressures to increase, poor blood flow, vascular insufficiency, resulting in bacterial overgrowth and inflammation. So a combination of all three with no treatment runs the risk of a perforation. So that is just an example for that pathophysiology right there, is a transverse compression graded ultrasound. Compression graded meaning we're going to put pressure on that. We do that several times when we're doing ultrasound. If we're looking for DVTs, if there's a thrombosis in the vein and we compress, it doesn't compress. Same thing here. We're worried about an appendicitis because there's that much fluid and that much pressure and obstruction there, and we cannot compress that. So that is just free fluid that's around there, indicative that there's significant inflammation, and then we can see the appendix right there. A little bit more into the pathophys. So viscerally innervated produces that vague, hard to localize, what we talk about peri-umbilical pain. And then the irritation that's going to classic migration to the right lower quadrant, where we're getting more peritoneal type of signs. So I need you to pay attention to this. So you're probably going to get pimped on it in phase 2. What is McBurney's point? That is exactly the spot that we push for rebound tenderness. I would definitely know that it is exactly 1/3 the distance from the anterior superior iliac spine to the umbilicus. Umbilicus, and please call it that. I called the umbilicus once in the OR, and you would have thought I killed somebody. It's just they get big on like the word. So umbilicus. And chest pain is not angina; it's angina. So they make a big deal about that stuff. So 50% may have an atypical presentation, may not be in that right lower quadrant. So if I were to think that I'm gonna try and confuse you and I tell you a pregnant woman, if she's pregnant, you would think gravid uterus would change out where that pain would be. It doesn't. Still, the right lower quadrant is still the most common. Still the most common. Now, what we do get concerned about is we have these retrocecal appendicitis. You look at that, that's 64%. So that's why that can have that, sometimes that little bit of atypical presentation. But remember, right lower quadrant, same spot, whether they're pregnant or not. So early symptoms of that, it's that non-specific malaise, indigestion, irregular bowels. They might complain, I feel like I have a stomach bug or gastroenteritis. So most common symptom besides that is going to be anorexia. They do not feel like they want to eat. Why? Because every time they eat, it's going to cause peristalsis, it's going to cause significant pain. Even worse than constant. It's kind of like colicky type of pain. So anorexia is common. Alterations in bowel function, that can be hyperactive or hypoactive. But again, that periumbilical pain, then the nausea, vomiting may or may not be present, and then subjective or objective fever. Subjective meaning they feel like they're hot. Objective meaning they actually do have symptoms or vitals consistent with a fever. So again, anorexia being number 2. That's why it's second on the chart there. So again, discomfort's going to migrate to the right lower quadrant. It can be accompanied potentially with flank pain, hematuria, dysuria, and that just has to do with the proximity of the appendix to the GU tract, the urinary tract. So these people can have pain with inspiration, which can be more a pleuritic type of chest pain. If that person tells you that they had the worst ride of their life coming to the emergency department because that person felt every pothole on the way there. So if this pain goes away suddenly, we do get concerned that that has ruptured. If it's ruptured, the pain's going to go away. That's very concerning. It's perforated, and then that makes it even more of a surgical issue. I had a 10-year-old young man that came in, right lower quadrant pain, had it for about 3 days. Thought, okay, appendicitis, start working him up. And the time that he was there, his mother dropped her purse. He jumped down from the gurney real quick and picked it up and jumped back in. And I was like, I can have an appendicitis. And my attending looked at me and goes, we need to get that kid to ultrasound now. He's perfect. And sure enough, he perforated. So sudden remittance of pain, like they had the worst ride ever, and they're like great, and they look awesome. Be worried that they ruptured. Considered appendiceal rupture, very concerning. That kid went right to the OR and had to get what remained of his ruptured appendix out. So again, we can start reproducing that tenderness palpation right lower quadrant, usually in the form of rebound tenderness at McBurney's point. But just be aware, sometimes you want to check to make sure there's no flank pain. No flank pain because it may be more of a retrocecal appendicitis. So that's where we have that costovertebral tenderness. So a lot of times those kids, I have kids jump up and down to check that. So, but you can tap on their right heel, and shaking of the hospital stretcher. I don't see why I would shake somebody's stretcher, but I would do a heel tap, definitely. So no need for rectal examination. No utility for that. So we have a Rosing sign. Everybody's familiar with these types of signs. Rosing signs just pushing on the opposite side, left lower quadrant. So that can create that pain. We're going to see it in a younger person. If we're pushing that left lower quadrant, and an older person, we probably should be a little bit more concerned of a diverticulitis type of pictures. And you have your psoas sign as well. So psoas sign, you can do that 2 ways. You can extend the right leg of the hip while the patient's lying on the left side. Or they can also be supine and extend the right leg against resistant, or supine with segment. So you can do that one of 2 different ways. And then your obturator sign, patient is supine, you're just going to rotate the right flex tip internally and externally to see if we can mimic that pain. So they say that rigidity, along with psoas sign, fever, and rebound tenderness, all increase the likelihood of appendicitis. So no one imaging or no one physical exam finding is going to support that, but if you have a combination of that. If they've had symptoms for a long time, there's no lower right quadrant pain, and there has been no pain migration, it decreases the likelihood. But no single physical exam findings, so make sure you're doing them all. So despite how much we have gone technologically with radiologic studies and whatnot, we have not increased our detection rates for that. So put a lot more credence in a good history and physical exam, OPQRST, make sure that you're putting hands on your patient, So it's largely a clinical diagnosis is what we're getting at here. So pelvic and testicular ultrasound, potentially if that's radiating pain is going down to the testicles. So just be aware of those appendix mimickers. So again, they have not had an appendectomy. We need to be very concerned putting that at the top of our differential. Here's a bunch of different things. So look at that, we have 12 different GI complaints for right lower quadrant pain, 7 GU, and then we throw in 2 musculoskeletal causes. So just have a wide differential on this. Again, looking at female patients between the ages of 10 and 19. So huge utility to get a urinalysis and a pregnancy test to guide this. See one on here that, who's familiar with a Meckel's diverticulum? Meckel's diverticulitis. It's a pediatric type of thing. It's a rule of 2s. That's usually right lower quadrant pain where they're gonna have a diverticulitis. Usually has a lot to do with lymphatic tissue. A lot of times, what are we gonna do with that? Ultrasound's not gonna tell us. That's gonna be scintigraphy. So red tag red blood cells. Red tag blood cell scan for that patient. Here's a nice tool. I'm not going to have you calculate the Alvarado score. I'm not going to have you calculate this, but I just want you to know that this can help you make a decision on whether or not the patient has appendicitis. It can help you make that decision. You're going to assign points for all these, so it gives you a good idea. So you can use this tool to help discharge patients home and say, I don't think it's a diverticulitis or appendicitis because you only have a 1 on the scale. Whereas I'm going to pick up the phone and I'm going to call a pediatric surgeon and say you need to come down and take care of this patient because I have an Alvarado score of 10. So max of 10, but you see the ones that hold a little more weight, tenderness in the right lower quadrant, as well as the leukocytosis. So you can say that those 2 findings, we'll work it up, are going to give you a little bit better idea of that. I just need you to know there's an Alvarado score out there that you can use this as a decision-making tool with whether or not you call somebody. In the meantime, we're going to get, said 2 points for that white blood cell count, so we want to get that. But it can be normal, it can be early. It'll be up to your institution whether or not they want an ESR or a CRP. These are evidence of inflammation. These hold a lot more weight in pediatric patients. Obviously, we want to get a urinalysis to make sure there's not something else going on, a pyelo. Again, we'll see sterile pyuria a lot of times based on the proximity to the appendicitis. And then again, an HCG, we want to make sure that we're not dealing with an ectopic pregnancy. Moving on, plain radiography, not helpful at all. No utility for this, no utility. Sometimes if they were to do that, it would support an adynamic ileus, which makes sense because we have an appendicitis going on. You're gonna have that stasis, everything's gonna slow down. And then occasionally they can see an appendicolith, not a fecalith. Appendicolith is calcified deposit of the appendix, usually collects their calcified deposit, and usually seen randomly in up to 50% of kiddos. And that just has to do because they have so much bone remodeling that's going on there. So they're gonna have a lot of extra calcium. But what are you gonna reach for? The graded compression ultrasound, initial modality in both pregnant females and children. And I'll tell you, if you work in a pediatric emergency department, they're gonna have some ultrasound techs that are pretty amazing at doing right lower quadrant ultrasounds and looking for those types of things. What are they looking for? They're looking for a thickened, non-compressible appendix, usually greater than 6 millimeters in diameter. So hyperemia with Doppler, they put that on there. It's gonna be, hyperemia is just increased blood flow. The body is trying to fight that, so it's gonna increase the blood flow to that. So we want to make sure that we image the entire length of that, both sagittal and transverse views. Sagittal and transverse views. So in the pediatric population, the sensitivity is much higher. Much higher. And why is it much higher? Because they're usually in pretty good shape. Okay? picture baby Jesus, but with better abs. They have no problem visualizing those scenes. Not a lot of adiposity, body habits and whatnot. Pretty easy to image those. So, other limitations though, we got that retrocecal appendicitis. So again, that's a large portion of those, 64%, difficult to see. So excessive abdominal gas or guarding makes it very difficult to look through and visualize those. If the patient is pregnant, or if they're obese, a little bit more difficult. Decompressed bladder, when we start ultrasounding each other, you'll be able to tell. So if somebody went to urinate right before they got an ultrasound, it's going to be very difficult to visualize through the bowel or through the bladder to see that right lower quadrant, and then lack of patient cooperation as well. So perforation, sometimes we aren't able to see that. If it did perforate it, we're not going to be able to have something that's non-compressible. Can be a little bit difficult. So in some cases, a pelvic ultrasound may be something that can be used and to find that appendicitis. Sometimes a pelvic ultrasound, usually that can be transvaginal or a pelvic ultrasound. So also just making sure that we don't have torsion, tubo-ovarian abscess, or ovarian cyst. How's that look on ultrasound? Right, like this. So this is in short, or it's also called transverse. So going across the body, short or transverse. So we can see that is 1 centimeter or 10 millimeters in size, non-compressible. Definitely want to fan through that entire appendix. So again, that's transverse across the body, versus the next one will be sagittal, which is with the length of the body. And you can see that right there. So longitudinal axis or sagittal axis, greater than 6 millimeters. I'm showing visualization of the distal end. Can also try and compress that way, not going to be as effective. A few more. This is in video. Anytime you're doing ultrasound, you can do video, it's going to be more effective for as far as recording your images, because it's not a snapshot in time. So graded compression ultrasound, similar to the concept of how we rule in or rule out a deep vein thrombosis of the leg. There's potential for CT. There's potential for CT. Most adult males, non-pregnant females. If we can't find that on ultrasound, we just go right to abdominal pelvic CT. So dilated appendix greater than 6 millimeters with thickened wall, paraappendiceal inflammation, and then potential for abscess or appendicolith. So comparing CT with that, yeah, pretty good, but most places are going to want the CT. A lot of these surgeons are going to want the CT scan because they want to see everything else that's going on. So again, it's going to say all those different findings on your radiologic report, and then it's at the bottom it's going to say findings consistent with acute appendicitis, like slam dunk, too easy. Oral contrast used to be a thing that they used, but that was if you had a little bit broader differential diagnosis, you were concerned about GI or pelvic issues, not needed to diagnose an appendicitis. So, plus PO imaging can sometimes cause emesis and contrast risk for renal injuries, so I want to use that with a grain of salt, and especially if somebody has a contrast allergy. That takes all the wind out of the sails, so we've got to be very careful with that. If they cannot handle that contrast for any reason, their contrast allergy, or you don't want to do that, there is potential that you can do in a pinch. If they are contraindicated to use IV contrast, you can do it with non-contrast. Just realize you're not going to get as good of imaging. But how does that look? Right there, dilated appendix. This is a coronal view, so it's like you are sitting or standing at the end of the patient's bed, looking up. This would be a slice from the legs into the abdomen. But they're also going to do this coronal views, but they're also going to do transverse. Much better idea. Much better idea. Coming back again, and obviously they gave you positive. That is monster, 17.1 millimeters. That guy's probably about ready to rupture. So positive arrow sign, probably appendicolith right there as well. So let's say we tried ultrasound, we tried CT scan, and we can't get anything figured out. There is a last-ditch effort. This is probably going to be done as an inpatient, but especially potential use in pregnant women and children. So no ionizing radiation, visualize the entire abdomen. I'll show you how that looks in a picture here. Some academic medical centers, not any that I've worked at, MRI was preferred over CT, but you better have the bandwidth to be able to do that. You better have a bunch of MRI scanners if you're going to be putting people in for this. So, but evaluation, especially in the first trimester of the pregnancy. In second and third trimester, it's okay to potentially use CT scan. Okay, we don't send anybody an MRI, especially if they're unstable. Why? MRIs take anywhere from 30 minutes to an hour. A CT scan can be done in 5 to 10 minutes, just to give you an idea of that. That's a long time for somebody to be in a scanner if they're unstable. Very difficult with kiddos though. If kiddos going to sit in an MRI scanner for 30 to 40 minutes and they're young, you're going to have to use conscious sedation, which is going to take you out of the mix for the entire deal too. How's that look on MRI? Right there. Right there. And again, pretty angry appendicitis. So again, if we're thinking about it, if I think anybody's surgical abdomen, I might, even if they're coming in abdominal pain, I'm going to make them PO tolerant right away. So most of these require appendectomy. There was a while where they were doing some trials where every appendicitis came in, they were offered either to go get surgery or to come in the hospital and get IV antibiotics. They were doing a trial on that. They came up to the patient with what their choices were. I had to call the surgeon and I had to call the rep to come in and give the antibiotics and get them admitted. So personally, I would get my appendix out because I don't want it. If you don't get your appendix out, you can still get another appendicitis. So why not just go ahead and get it out? So very common surgery. You should get to see plenty of these in phase 2. But again, MPO, nothing will get a surgeon more upset than they come down to take the patient off to surgery and they're eating. They will get very upset about that. So make sure that we're resuscitating the patient appropriately with IV fluids, antiemetics. We don't withhold that analgesia. And a lot of times there are going to be peri-operative antibiotics. I will talk to that surgery team and say, hey, what's your flavor of antibiotics? Most people it's going to be Zosyn and Vanc, but sometimes you want to add different things to that. So, and this is just what I alluded to. I can't remember the trial. I think it was a COPA trial or something like that. It was a few years ago. I don't see it anymore. Again, they were doing non-operative. I don't want to go to surgery. I'm just going to do IV antibiotics. Here's some of the medications. Again, I don't worry about doses. But you got Zosyn right there. So you need to have a good understanding of your trade names as well as your generic names. Good understanding of that. So Unison, Zosyn, Ceftoxin, metronidazole plus Cipro. Again, I usually ask. I don't even start any of these antibiotics until I talk to the surgery team and say, hey, what do you want me to start? And then, of course, you're cross-referencing that with any allergies that your patient has. So that's just the last thing when I finish up that consult. I usually say, bottom line up front, I got a 24-year-old down here with acute appendicitis. What else? What do you want to hear about them? Sometimes they're just like, they're so busy, they're just like, okay, cool, we'll be right down. Or they might say, hey, I want you to give me the whole spiel, and then I'll give them the whole stuff and tell them, leukocytosis, classic migration from the from the umbilicus to the right lower quadrant, ultrasound if they're pregnant or a kiddo, CT scan likely if anybody else. So disposition, surgery is the answer here. They don't send people home that have an acute appendicitis. You need to get that taken care of because if that ruptured, it can be devastating. So there's potential if you can. It's not a slam dunk, but you have your leukocytosis. You have high enough Alvarado score. You can say, hey, I think I want to get you admitted for serial exams, serial labs, because I think we may have just caught it early. These are what we call first world problems. People will have the access to healthcare, maybe they come in a little bit earlier than they would. So if they can come back within 12 hours, it's not completely, it's super, super early shared decision-making with your attending yourselves. There's potential that they can say, hey, I'll come back 12 hours from now. That's provided there's pain is under control, usually not with narcotics. Okay, and they can tolerate oral hydration, they are PU tolerant. So discharge instructions, anything changes, you come back earlier. All right, questions? I'm really dreading Friday. 1500? I talked to the academic coordinator about that. It's not cool. Questions, questions, questions. All right, we're gonna remember, right? It's women, 1 out of 4, but 10 to 19 doesn't mean you can't have an appendicitis much later, but that's just gonna be your comment.
C. C for initial.
The key to that is initially evaluate. So we never want to radiate somebody initially. So everybody's good with abdominal ultrasound, correct? Keep in mind, probably going to be a little bit more difficult. 7 months pregnant is going to be pretty significant gravid uterus. Not everybody has a fever. Not everybody has diarrhea. I told you what this one was. It's second on the table, so they're not anorexia. It's going to be your number 2. Right lower quadrant pain be number 1. Anorexia be number 2. It's plus or minus with the fever. It's plus or minus with the nausea and the vomiting. Told you, don't let the gravid uterus throw this off. It's still gonna be in the same place, right? Right lower quadrant C, still in the same place. But to get this one right, you have to make sure you know where the descending colon is. You guys should be way past that. I said should.
Hey.
Everybody's good with Rosen, right?
Yeah.
Good. Hey. I have lots of, these are a lot of hence-isms. They're gonna say initially and first. So obviously we're gonna reach for ultrasound on the kiddo. Then we can potentially move on other things. I would not subject a 7-year-old to a transvaginal ultrasound. That's just not okay.
Prison.
Sudden remittance of pain, that's ruptured or perforated. Alrighty. Get you out a few minutes earlier for